Cancer Conversations, a Harold Leever Regional Cancer Center podcast discussing all things cancer and giving you information to improve yours or a loved one's cancer journey. Hello and welcome to Leever Cancer Conversations from the Harold Leever Regional Cancer Center. Today we're happy to welcome Dr. Elizabeth Reardon, MD, board-certified general surgeon specializing in breast surgery, to talk about breast cancer. Dr. Reardon is a member of the American Board of Surgery, the Connecticut chapter of the American College of Surgeons, and the American Society of Breast Surgeons. Today we'll be discussing breast cancer, prevention, symptoms, screening, and treatment. Hello, Dr. Reardon, you're very welcome.
Good morning, and thank you for having me.
Well, to get started, let's have you tell us a little bit about yourself.
After high school, I went to North Carolina at Duke University, spent a year after college at Columbia University getting my master's in human nutrition, and back to Connecticut to do my medical training at the University of Connecticut Medical School. From there, I went to New York and did my general surgical training at Stony Brook University Center.
Excellent. And what is it that you do now?
Well, I have always treated women and men with breast concerns, but earlier in my career, I took care of all general surgery, including trauma and critical care, laparoscopic, etc. But for the past 27 years, I've provided breast care to both men and women, and that would include all benign concerns as well as breast cancer treatment. And that's what I have been doing for the past 3.5 years here at the Waterbury campus as part of the Greater Waterbury Cancer Center, which includes Waterbury Hospital, St. Mary's Hospital, and Yale University, where we come together at the Leever Cancer Center, also located in Waterbury, to provide patients the best cancer care and benign breast care that you can get.
Sounds great. So let's talk a little bit about breast cancer. What can you tell us in general about breast cancer?
Well, breast cancer is obviously a concern of many people. If we stop to look at the number one risk for getting breast cancer, it's being female and having breasts. So that includes a lot of folks. It continues to be a significant cancer in terms of the numbers of cases that we see yearly. We are very committed to helping women to help themselves and to getting women diagnosed early. So we know that in the entire country, there's about 240,000 cases of breast cancer a year. For every 100 women who have breast cancer, we have one male who has breast cancer, and that amounts to approximately 2,100 cases of male breast cancer a year. The interesting statistic is we are getting better at treating it, and fewer people are passing from breast cancer. We still see about 42,000 women and 500 men in the United States die each year from breast cancer. And so we like to educate people to be aware of the disease and what they can do to help their own case. How can they participate in their own care?
Well, that's a great entree into talking about prevention. What can people do to help prevent breast cancer?
Well, I approach that topic from several angles. One is addressing what a woman can do herself to improve her chance of not getting breast cancer, but also to be aware of the things that are not necessarily under her control. So what is it we can do to actually help ourselves? Well, there's a couple of things that we know from looking at large groups of women over long periods of time that seem to diminish the chance of getting breast cancer. I would call them fairly obvious things like being fit. We know that women who maintain a healthy body weight, get regular exercise, at least 3, maybe 4 half-hour sessions of vigorous exercise a week, eating more fresh vegetables and fruits, staying away from fried, processed foods, less red meat, less fat, And not smoking. We know that women who smoke over a lifetime are on average 40 to 60% more likely to get breast cancer. And last but not least, less alcohol. 2 alcoholic beverages a day chronically has been associated with an increased risk of breast cancer development. So those are things that we can control for the most part. Other things that are less in control. We know that women who have early menstrual cycles and go into menopause later in life have a slightly increased risk of breast cancer. Why? Because a majority of the breast cancers diagnosed in the United States are sensitive to our female hormones. But supplementing estrogen and progesterone after our menses cease has been associated in the past with an increased risk in breast cancer. Now, as opposed to 20 years ago, we are well aware that not all postmenopausal hormonal replacement therapy is associated with an increase in the risk of the development of breast cancer, but combination can be. So I always advise my patients that that's a discussion that we have with our gynecologists when and if that's an issue when we reach menopause. How can we safely transition into menopause without increasing our risk of breast cancer?
What about genetics and family history with cancer?
That's unfortunately not in our control. We are born into the family that we have. And so our genetic predisposition for cancer is given to us prior to our birth. While we can't impact what we've gotten from our relatives, we can at least be aware of our family's medical history. How many women had breast cancer, if any? How many women had ovarian cancer? Is there a lot of cancer in general in the family? How old were relatives when they got cancer? And whether or not people have been identified within the family as having a genetic mutation that increase their risk of getting breast cancer. Dense breast tissue is thought to slightly increase a risk of the future development of breast cancer. If a patient has had biopsies that have atypical cells or proliferative disease are things that grow in the breast that necessarily aren't cancer, but don't belong there anyways. Those types of things we know slightly increase our future risk of breast cancer. That's how we personalize a patient's risk for ongoing breast cancer.
How would a person know they have breast cancer? What are the symptoms to look for?
Being aware of your own body, of your own breasts, is very, very important. And so we teach women early on, age 18, to start doing self-breast examinations. Why? We don't expect people to know what a cancer feels like. I mean, the average woman doesn't, nor do we expect them to find a problem if there is one. But what we teach women is if they get in the habit of routinely checking their breasts as little as once a month, and for women who still get a menstrual cycle, the best time is to check yourself right after your menstruation stops, because that's the level with which our own female hormones are at their lowest levels. Our breasts are less sensitized by our female hormones. And if there is anything to feel, you're more likely to feel it when your tissue isn't sensitive, or, as most women experience at the height of their menstrual cycle, more dense. It's a very important tool that costs us nothing and is fairly easy to do. So it's available to everybody to check themselves once a month. Other things you should look for when you get out of the shower, go up to the mirror and just put your hands on your hips and look at yourself in the mirror. Changes in the appearance of breast tissue, both in the contour of the tissue, the appearance of the nipple in relation to the rest of the breast. Are there any puckers in the skin? Did you notice a little ripple that you didn't notice before? Is there something on the nipple or areolar complex. These are visual cues that perhaps you should seek attention to have somebody assess you so we can either confirm or deny that this is an issue for you. Other things that we look for, nipple discharge that is bloody. Lots of premenopausal women get discharge of all sorts of colors, light yellow, light green, light brown. And that's actually indicative of cystic breast pathology, but not necessarily cancer. If a woman were to see blood consistently coming out of the nipple, that's one of the triggers that we teach patients they should at least seek assistance. Interestingly enough, pain that's out of the ordinary or atypical is not usually associated with breast cancer. So if women have pain, we still encourage them to seek assistance. Interesting, pain is not on the list of things that we immediately think cancer is related to. If women were responsible for those things, I think we would see a lot of early stage diagnoses and far fewer later stage diagnoses. If there's a problem, call somebody. Don't keep it to yourself. If it's not cancer, great. No harm, no foul. But at least try to reach out so we can help you to help yourself.
Great. So we know that some breast cancers are found by the patient. However, the majority of breast cancer is found with routine imaging. What types of imaging is used to detect breast cancer?
Well, there are three primary recommended ways. The most recommended way would be your mammogram. A mammogram is an X-ray of breast tissue. Looking within the tissue, it is something that you can pretty much find anywhere. We even have mobile mammography units for people who can't get in to a doctor's office or a mammography center. I will also point out that mammograms done today compared to mammograms 20 years ago are so much more efficient at finding things. They're now digital images, and the standard of care, at least here in our Waterbury community, is the 3D mammogram, where not only do we get stagnant pictures of the breast, but images are stacked on top of one another, so radiologists can go through the breast tissue, especially in the dense areas, to see if anything's going on. So mammograms today are better than they ever have been. The second tool that we have is the ultrasound. For the most part, ultrasounds are used in two cases. One, if you're dense breasted, we would order an ultrasound automatically on dense breasted women. We also order ultrasounds quite commonly if a patient has a complaint, say of I feel a lump, or I see nipple discharge, or I have pain. It's just another way for us to identify what might be causing the patient's symptoms, and therefore we can then formulate a plan based on patient complaint and their imaging. Last but not least, there is the MRI. So it's a much bigger test. It's a long test, and for the most part is not used on the average patient to screen for cancer. Frequently, MRIs are used to better identify an area of concern. So if someone has a complaint and we do imaging, and there is a concern that something might be going on in a part of the breast, we can either biopsy that area or we can get more information about it and utilize an MRI. An MRI is also used in our breast cancer patients who have certain types of cancer. Last but not least, are high-risk patients. In 2017, our Society of Breast Surgeons came out with a standard statement. Women who are considered at high risk, which is greater than a 20% risk of getting breast cancer throughout her lifetime, would be considered high risk. And those women benefit from having more imaging. So once a year, that patient would have her routine mammogram plus or minus an ultrasound, depending on the density of her breasts, followed by a physical examination with the breast surgeon, and then also have a yearly MRI of the breasts separated from her usual imaging by 6 months to make sure that we're extra careful about looking through the breast tissue as the patient is at an increased risk.
So let's move on to screening. Can you talk about how important screening is?
Well, like we've already mentioned, that a majority of breast cancers in our country today are not felt or noticed by the patient. They're found on imaging. We recommend starting imaging at 40, getting your mammograms plus or minus ultrasounds, as we've already discussed, based on the density of the tissue. For people who have a first-degree relative who has had breast cancer, whether or not we've identified a genetic abnormality that led that patient to be more at risk for breast cancer, the standard of care is to start screening imaging a full 10 years prior to that patient's first-degree relative. So, for instance, if your mother had breast cancer at 45, I would recommend that her daughter have her screening imaging at 35, as opposed to waiting to her 40s.
So then, when a patient has been referred to a breast surgeon, what information do they need to gather before the appointment?
We do our very best to gather as much information about that person before she walks through the door, because not only do we address a patient's concern, or if they're referred because of a problem on their imaging, we also calculate for that patient their personalized breast cancer risk. So the information that, as a breast surgeon, that I'd want to know is, when did you first start your period? And if you're postmenopausal, when did that happen? Did you ever take postmenopausal hormonal replacement therapy? We know also that the number of pregnancies can be impactful for risk. We've already mentioned that a woman who's had a long period of time where she's subjected to her own estrogen is more at risk. We also know that if a woman has been pregnant several times, that may also impact her risk. Another thing is breastfeeding. We always want to know, did patients breastfeed? Women who breastfeed for more than a year actually may enjoy a slight diminishment in their ongoing risk of breast cancer. We always get height, weight. We calculate their body mass index, which is a very common tool where we compare the weight of a patient to the height of a patient to see, are they at a good, healthy weight? We want to know, have you ever had a breast problem in the past? Have you ever had biopsies? Have you ever had surgery? We're nosy, I'm not going to lie. We want to know where, and we want to know what. We do hunt down that information because it might be impactful. And then, of course, the family history. Who had cancer? What age they had cancer? Were they ever tested? All of that information is very important to giving the patient the best experience overall in their assessment of whatever their breast concern is when they walk into the office.
Great. So you take all that information into account, and then let's say a patient is diagnosed with breast cancer. What are the different types of surgical intervention that may be needed?
In the last 30 years, it has changed a lot. We know historically, women who had breast cancer, they all got the same procedure. They had their breast with the skin and the nipple and the underlying muscle all removed, including every single lymph node underneath the arm. Now, we know that women who have smaller breast cancers don't necessarily have to lose their entire breast. They could have what we call a lumpectomy, which is just removing the tumor itself. And then, if they qualify, we treat the remainder of the breast with radiation therapy if indicated to diminish the risk of recurrence. For women who have invasive cancer, in addition to getting rid of the tumor itself, we do have to check their lymph nodes. Taking a lymph node, just one or two, in a patient who has a small early breast cancer is now much more standard of care than going in and taking all of them. Mastectomies are still done today, but we recommend mastectomies only in patients who have lots of disease throughout their breast in more than one place, very large tumors that are not able to be treated with medicine or patient preference. And I have to mention her. Angelina Jolie is a good real-time example of a woman who was born with a genetic mutation that increased her risk of getting breast cancer. She chose to have a bilateral mastectomy, never having had a breast problem. But she knew that her chance of getting one in the future was high, so she opted to have her breast removed before she had a problem. Other than actually taking the tumors out and checking the lymph nodes, women also have to know that there are lots and lots of options for reconstructing a breast. Now more than ever, there is a big concentration on oncoplastic surgery that takes care of the cancer, but also makes it look good too. Reconstruction can be as little as just rearrangement of native tissue at the time of their cancer surgery, so it evens out with the opposite side, or fixing the opposite side to make it look more like the cancer side. We have, for patients who've had full mastectomies, reconstructions so that they can either opt for implant reconstructions, or we have several techniques that use their own tissue to reconstruct one or both breasts.
Well, it sounds like there are lots of people involved in the journey, lots of providers involved. And that takes me to my next question to talk about the breast cancer team. Could you talk about that?
Absolutely. The standard of care in the approach to breast services is a multimodality approach. It's not just a medical problem. It's not just a surgical problem. Breast cancer care in our world is treated by lots of people. For every patient that is diagnosed with breast cancer, we bring them to our Leever Cancer Center, where we talk about their case to a group of participants that include every aspect of that patient's cancer journey. So the presenter will talk about what the patient came in with, what were her symptoms, what was the exam like, what we learned from that. Then we have our radiologists who bring in the imaging, what was found on the imaging, what we did to find the problem at hand, and any recommendations going forward. Our pathologists go over the pathology. We actually look at what the cells look like. We talk about the characteristics and the biology of the cancers. How do they act? What their characteristics are, and how we can tailor each and every patient's care to their tumor. Our medical providers, our oncologists, they're there to review the cases, and then we chat about what is best practice for this patient. All of our professionals, even though the patient may only meet one oncologist after her surgery or her diagnosis is made, she really has the opinion of everyone in the room, because we all practice consensus of care, which is we all talk about that patient's problem, and we bring to the table our own personal knowledge and our understanding of the disease processes. We have our radiation oncologists who can offer radiation therapy in order to diminish the risk of that tumor coming back. Sometimes patients with aggressive disease or patients that have lymph nodes that are positive will need radiation even if they've had a mastectomy. We have our nurse navigators that help patients through the system to make things easier on the patient so that they can get their appointments in a timely fashion, get their treatments as soon as possible. We have our social workers who are intimately involved in helping patients that need social service resources. Our lymphedema specialists weigh in on every cancer in order to best serve our patients before, during, and after their active treatment. Our nurses are there, the people who help give chemotherapy, help deliver the radiation therapy, and who help coordinate the breast cancer center itself. You don't have to go into New York City or Boston to specialty places because we offer the same care right here in Waterbury. We're trying to make it easier for patients to get the best care right in their own backyard.
I love that. We have covered a lot of information today. Let's summarize what it is that we have been talking about.
First and foremost, pay attention to your breasts. Examine them, look for differences, any problems, please reach out to your gynecologist, to your primary. 2, know your family. Is there any history? Who, when, where? Is there any genetic abnormality? These points could be vital, not just in treating a problem you may have, but preventing future problems. We talked a lot about a healthy lifestyle. Whereas 1 in every 8 women, by the time we reach 84, the average life expectancy, is going to get breast cancer. What we can do for ourselves to limit or diminish that risk, obviously, would be recommended. So exercise more, less alcohol, no smoking, maintaining a healthy weight, less preservatives, more fresh fruits, less fat, less grease, less red meat. That is within our control to limit. And doing your screening imaging, following up with your physicians, get your mammograms and ultrasounds, and don't keep problems or concerns to yourself. We're all here to help.
Great. So do you have any final thoughts to share?
I would like to acknowledge the importance of every aspect of our center. And what I love about our community is everyone has this real commitment to being the best at what their specialty is, to best serve our patients. So from a personal standpoint, I'm very proud to be here now doing what I do in this community.
Wonderful. Well, we're very happy that you're in our community too.
And thank you very much. I appreciate being here, and I appreciate the opportunity to address your audience to help people get going on their own breast health.
Well, thank you for being with us today and sharing your expertise, and we look forward to talking with you again in the future.
My pleasure, anytime. Have a wonderful day.
Be sure to check out our website, levercancercenter.org, for more great content and new podcasts. Content produced by Leever Cancer Conversations is for the community and is for education purposes only. We do not diagnose, treat, or offer patient advice. Thanks so much for listening.